Good evening. First of all, I would like to thank the Dermatology Student Club for giving me this opportunity. Let me introduce myself. I'm Rasha AlHamzani, medical intern, and I matched in dermatology at King Fahd Medical City. Today, I'm going to talk about one of the most common disease in dermatology, which is psoriasis. Inshallah, today I will cover the definition of psoriasis, epidemiology, etiology, pathophysiology of psoriasis, classification of psoriasis and the clinical features, subtypes, and variants, comorbidities with psoriasis and complication, and also how to diagnose the psoriasis and management. First of all, what is psoriasis? Psoriasis is a chronic inflammatory skin condition characterized by clearly defined red and scaly plaques. Psoriasis is not affect the skin only, it is multi-system disease with predominantly skin and joint manifestations. Comorbidities with psoriasis include coronary artery disease, metabolic syndrome, and depression. The nature of psoriasis, it is a chronic disease that waxes and wanes. Actually, it is not curable, but control of the disease and comorbidities are achievable. The epidemiology of psoriasis, it is the prevalence around 2 to 3% of the population worldwide. There is racial difference in psoriasis, higher in Caucasian and lower in Africans, Americans, and Asians. Both male and female sexes are equally affected, and psoriasis show bimodal age peaks, but can happen actually at any age, but the most commonly is between 30 and 39 and 50-59 or 60-69. So what is the etiology of psoriasis? Actually, psoriasis is a multifactorial disease. Both genetic predisposition and the triggers factors plays a role. Genetic predisposition most likely determined by polygenic inheritance, and the triggers factors include infectious, like infections of the upper respiratory tract caused by beta hemolytic streptococci, and also staphylococcal infections, HIV, and also mechanical irritation and trauma, which show Koebner phenomenon. I will talk later on about the Koebner. Smoking and alcohol and stress also play a role. Obesity mentioned as a trigger factor. So what is the pathophysiology of psoriasis? It is T-cell driven immune dysregulation, and this is the main pathogenic statement. And also, as I mentioned, psoriasis is multifactorial, both genetic predisposition with environmental triggers play a role. The genetic predisposition, like human leukocyte antigen CW6 allele source1, has the strongest genetic association among at least 8 chromosomal loci identified, source 1 to 8. It is a complex immune-mediated disease in which T lymphocyte, dendritic cells, and cytokines play a central role. Interleukin 23 and interleukin 17 and tumor necrosis factor play the major role or the major messengers in psoriasis. So as you see here, environmental triggers, as I mentioned before, and genetic susceptibility lead to keratinocyte injury and increased antigen presentation. This will lead to increased production of pro-inflammatory like interleukin 23 and interleukin 12, which lead to activation of T cells by myeloid dendritic cells, leading to T helper 1 and T helper 17 activation and proliferation. This will lead to produce more and more of the cytokines, and the tumor necrosis factor. This will lead to increased production of the beta defensins and epidermal acanthosis and abnormal keratinocyte proliferation. So what is the clinical features of classic psoriasis? The course of psoriasis is relapsing and remitting with symptom-free intervals. And the lesions, initially a few single lesions typically appear, which often then become confluent. The lesions characterized by well-defined and sharply demarcated lesions, round to oval shaped lesions, usually symmetrical distribution, and it is erythematous raised plaques covered by silvery white scales. Remember that psoriasis is non-itchy, but itching occurs in flexural psoriasis and may be psychogenic or irritation of topical agents. So the lesions characteristically show the OSPIT sign. What is the OSPIT sign? OSPIT sign refers to the appearance of the small bleeding points after successive layers of the scale have been removed from the surface of psoriatic papules or plaques. As you see here, after we remove the scales, the pinpoint bleeding appears. Also, Itchua-Kubner phenomenon refers to the emergence of the new psoriatic lesions in the healthy skin regions following an injury or trauma to the psoriatic patients. As you see here, the emergence of psoriatic lesions over the site of the wound. What is the most common sites of psoriasis? Elbow, knee, scalp, and sacrum. We mean mainly the extensor surface, but can actually affect any site of the body. So now I'm going to talk about the types of psoriasis. There's many types of psoriasis. One of them is chronic plaque psoriasis and inverse psoriasis, which is called flexural psoriasis, Guttate psoriasis, erythrodermic psoriasis, and postular psoriasis. More local forms like scalp psoriasis, palmoplantar psoriasis, and nail psoriasis. Chronic plaque psoriasis, actually, it is the most common type, around 80 to 90% of the patients, persistent and treatment resistant. The lesions characterized by well-defined and sharply demarcated lesions, erythematous plaques covered with thin silvery white or mucous scales. It is irregular, round to oval, ranging in size and number, may coalesce into larger plaques, and usually plaques more than 3 centimeters. Sometimes maybe there is painful fissuring can occur in lesions over the joint lines or palms and soles. So chronic plaque psoriasis is symmetrically distributed. Most common sites are scalp, extensor surface, like elbows, knees, lower back, and inner gluteal areas. Severity, around 80% of the patients have mild to moderate disease, and around 20% of the patients have moderate to severe disease. As you see here, there is well-demarcated erythematous scaly plaques over the extensor surface of the legs, knees, and elbows. And as you see here, it is symmetrically distributed. Let's move on to the inverse psoriasis, which is called flexural psoriasis. It actually affects the skin folds as axillary, inframammary, perineal, and genital areas. It is a smooth, red, well-defined patches, usually devoid of scales due to the continuous friction and moisture at these sites. Itching is a common symptom, and it may be colonized by candida yeast. As you see here, it is well-defined red patches in the inframammary and umbilicus. And you see here in inner gluteal and inguinal, and here in genital. Guttate psoriasis. It is less than 2% of the patients typically appear less than 30 years. The lesions are characterized by the size of drop of water, ranging from 1 to 10 millimeters, salmon pink papules with less scale than plaque psoriasis. Primarily affects the trunk and the proximal extremities, often preceded by group A beta hemolytic streptococci upper respiratory tract infection by 2 to 3 weeks before the appearance of these lesions. Can be the first manifestation of psoriasis or an acute exacerbation of long-standing plaque psoriasis, often resolve after several months. As you see here, widely distributed erythematous papules over the trunk and the proximal extremities with minimal scales. Erythrodermic psoriasis. It is generalized erythema and scales covering entire skin surface, may evolve slowly from chronic plaque psoriasis or appear as eruptive phenomenon. Patients may become febrile, hypothermic, and dehydrated. This is due to the increased cardiac output and blood supply to the skin. Complications include cardiac failure, as I mentioned, increased blood supply and cardiac output to the skin, infections, and malabsorption and anemia, relatively uncommon. As you see here, generalized erythema and scales over all the body most commonly affect more than 90% of the body surface area. Postular psoriasis. It has two types, may be localized or generalized. Localized postular psoriasis, like palmoplantar psoriasis, it is recalcitrant postular eruptions of extremities, a chronic relapsing disorder occurring on the palms and or soles. The lesions characterized by crops of the small, deep-seated sterile pustules are seen within areas of erythema and scaling. The sites of predilection are the mid-palms and thinner eminences of the hands and heels. As you see here, there's multiple pustules within area of erythema and scaling on the soles and palms. The other type is generalized postular psoriasis. It is an acute, uncommon, severe form of widespread pustules on an erythematous background with fever and toxicity. Precipitating factors as infections, sunburn, pregnancy, hypoglycemia, irritating topicals like tar, dithanol, drugs as progesterone, and corticosteroid withdrawal. Let's talk about more localized forms of psoriasis like scalp psoriasis. Scalp psoriasis, often the first or only site of psoriasis. The lesions characterized by discoid lesion or band-like erythematous scaly plaque along the anterior hairline. We differentiate it from seborrheic dermatitis by that the scalp psoriasis is dryness, absence of itching, absence of hair loss, and predilection to the frontal scalp margin. As you see here, it is erythematous scaly plaques along the anterior hairline. Palmoplantar psoriasis, typical thick, silvery scaly plaques, non-itchy and well demarcated. We differentiate psoriasis of the palm from eczema by the sharp margination at the wrist. As you see, the sharp margination at the wrist. Nail psoriasis, nail involvement in 10 to 55% of the patients may be present in patients with any type of psoriasis. Can take several forms like pitting, sublingual hyperkeratosis, onycholysis, oil drop sign, and nail dystrophy. Pitting, the pitting is discrete, well circumscribed depressions on the nail surface, as you see here. and subingual hyperkeratosis, silvery white crusting under the free edge of the nail with some thickening of the nail plate. And here onycholysis, nail separates from the nail bed at the free edge. Oil drop sign, a translucent yellow-red discoloration in the nail bed proximal to the onycholysis. It reflects inflammation and can be tender. Nail dystrophy, distortion and discoloration of the normal nail plate structure. So what is the comorbidities and complications with psoriasis? As I mentioned before, psoriatic arthritis, cardiovascular disease and metabolic syndrome, autoimmune disease, psychiatric and psychological disease, and also psoriasis affect the quality of the life. Psoriatic arthritis, an inflammatory arthritis with negative rheumatoid factor associated with psoriasis. 30 to 33% of the patients with psoriasis have psoriatic arthritis. Nail affection occurs more frequently, around 80 to 90% of the patients with psoriatic arthritis have nail affection. The lesions of the psoriatic arthritis characterized by erosive arthritis, enthesitis, and dactylitis. And the most common site is inner phalangeal joints, wrist, ankle, elbow, spine, and sacroiliac joints. In 50% of the patients, psoriatic arthritis occurs before psoriasis, and delay in diagnosis of or inadequate treatment can result in permanent joint destruction and significant morbidity. So we should screen the patients for arthritis at each visit. One of the comorbidities with psoriasis is cardiovascular disease and metabolic syndrome. So what is metabolic syndrome? It is a group of disease like obesity, diabetes, hypertension, and atherogenic dyslipidemia. Increased incidence of myocardial infarction in patients with psoriasis, especially in severe psoriasis, and also increased mortality risk from all causes or in a dose-response manner with disease severity and from several specific causes such as cardiovascular, liver, kidney, and infectious disease. Autoimmune disease also, there is higher incidence of Crohn's disease and ulcerative colitis in patients with psoriasis than in general population. And there is possible link between multiple sclerosis and psoriasis, as psoriasis occurs more commonly in families of patients with MS. So what is the psychiatric and psychological disease, and what about quality of life in psoriasis? Psoriasis can have a substantial psychological and emotional impact on an individual, which is not always related to the extent of the skin disease. The patient with psoriasis have poor self-esteem, sexual dysfunction, anxiety, depression, and suicidal ideation. Prevalence of the depression is very high among patients with psoriasis, and the occupational function and the QOL impact can be significant even in patients with small areas of involvement, and may be considered candidates for systemic therapy, like patients with scalp or bones and soles psoriasis. So how to diagnose the psoriasis? Psoriasis, mostly a clinical diagnosis. So we diagnose the psoriasis clinically by the clinical manifestation. But sometimes uncertain cases may require a skin biopsy for histopathology confirmation. As you see here, this is the skin biopsy, which is called bunch biopsy. How to assess the severity of psoriasis? We have many tools for the assessment of psoriasis, as psoriasis area and severity index. This is most commonly used in clinical trials. Score indicates severity of the disease at a given time. and single number that considers severity of the lesions and extent of the disease across 4 major body sites like head, the trunk, upper limbs, and lower limbs. Score ranges from 0, no disease, to 72, maximal disease. Body surface area involvement, this is the simplest one, and Dermatology Life Quality Index. The other is the psoriasis QOL 12 items instrument. Severity of psoriasis can be classified as follows. We consider psoriasis mild, less than 2% of the body is affected, and moderate from 3 to 10% of the body is affected. Severe, more than 10% of the body is affected. Of note, the palm of the patient's hand is equal to 1% of the body surface area. So let's talk about the management of psoriasis. The goals of management is to slow the rapid turnover of epidermis and to promote the resolution of psoriatic lesions, to control the natural cycles of the disease and achieve long-term remission, and also improve the quality of the life. Please remember that there is no known cure for psoriasis. We follow step ladder approach or stepwise approach. If the patient came with mild psoriasis, we start with avoid the triggers, moisturizers, and topical. If the patient have mild to moderate psoriasis, we use phototherapy and systemic. If the patients with moderate to severe or severe psoriasis, sometimes we jump to systemic biologics. General measures before startment of the treatment, reduce and eliminate the potential triggers as stress, alcohol, trauma, drugs, as I mentioned before, and infection. And the patient should maintain optimal weight. So topical therapy, approximately 70% of the patients with mild to moderate psoriasis can be managed with topical therapy alone, like emollients, coal tar preparation, ditranol, salicylic acid, tazarotene, a type of retinoid, vitamin D analog like calcipotriol, topical corticosteroid, and combination of calcipotriol, betamethasone ointment, gel or foam, and calcineurin inhibitor like tacrolimus. Let's talk about emollients. Include aqueous cream, sorbolene cream, white soft paraffin, and wool fats. The regular use of emollients can alleviate pruritus, reduce scale, and enhance penetration of concomitant topical therapy. Also hydrate dry and cracked skin. Remember that soap should be avoided in patients with psoriasis. Coal tar help reduce inflammation and pruritus, and also may induce longer remissions, but use limited by distinctive smell and ability to stain clothing and skin. And also, as a side effect, may cause local skin irritation. Ditranol, it shows anti-proliferative properties and particularly effective in thick black psoriasis. Initiate therapy at very low concentration because there is a risk of burn of the skin. Not suitable for face, flexors, or genitals, and also it may stain the clothes permanently and skin temporarily. One of the topical treatment is keratinolytics as salicylic acid and urea. This type of topical treatment helps dissolve keratin to soften and lift psoriasis scales and may enhance penetration of other actives. Tazarotene, topical synthetic retinoid for treatment of black psoriasis, applied once daily in evening, and one of the side effects, it can cause local irritation. Corticosteroid, it considered the first line of the treatment. both is anti-inflammatory and anti-proliferative and immunomodulatory properties, reduce superficial inflammation within plaques, and potency choice depend on the severity of the disease, location, and patient preference. Adverse effects associated with long-term use include skin atrophy, hypopigmentation, striae, and telangiectasia. Calcipotriol, one of the topical treatment, it is a synthetic vitamin D analog for chronic plaque psoriasis, reverse abnormal keratinocyte changes. This is the action of this treatment. And the adverse effects include erythema and irritation. There is also a combination of calcipotriol and potent topical corticosteroid like betamethasone. It's provide rapid, effective psoriasis control, once daily treatment with the potential to improve compliance. Most common adverse events include pruritus, rash, and burning sensation. Also, one of the modality of treatment is phototherapy. Often, we use it in combination with topical or systemic agents, and there's many type of phototherapy include narrowband UVB and broadband UVB, photochemotherapy, and targeted phototherapy. Systemic therapy, like immune suppressant, for example, methotrexate, but remember that it is effective but hepatotoxic, and we need to supply the patients with folic acid because methotrexate is antifolate. Azathioprine, mycophenolate mofetil, cyclosporin, but cyclosporin has nephrotoxic and may lead to hypertension as a side effect of it. One of the treatment is oral retinoids like acitretin. It is teratogenic, and contraception is recommended for all female patients of childbearing potential 1 month before, during, and 3 years after therapy. Finally, the most effective therapy for severe psoriasis is biologics. Biologics like tumor necrosis factor alpha inhibitors, Enbrel, adalimumab, which is called Humira, and infliximab, and also interleukin 12-23 blocker, interleukin 17 blockers, and interleukin 23 blockers. This is the references of my lectures, and thank you for your attention. If there are any questions, I will be happy to answer them now.
يعطيك ألف عافية دكتورة رشا. The presentation was very nice, especially considering the topic is psoriasis.
Thank you.
على بال, as attendees know, they can definitely send their questions in the chat and the Q&A, and I will read them to دكتورة رشا. أنا actually عندي سؤال إذا ممكن.
تفضلي.
When do you usually introduce phototherapy into the treatment? يعني تبدون topical with the corticosteroids to induce.
Yes.
Then you can use either the calcipotriol to continue remission. When do you start putting in the phototherapy?
Sometimes we start phototherapy as a combination with topical. If the patient no response to topical, we start combined to topical and phototherapy. But there is no compliance from the patients with the phototherapy.
تمام, شكرا دكتورة.
الله يعطيكم العافية. Any question?
Yes, we have a question. Could you explain the difference between the Koebner phenomenon and pathergy test?
Koebner phenomenon, when there is a trauma or irritation to the skin, like in the knees from friction or any injury to the skin. After that, it will appear a new psoriatic lesions in the same site. The other test, actually, I don't know what is it.
Okay, أتوقع those are all the questions right now about psoriasis. شكرا دكتورة رشا for
Thank
finishing
you.
our first day of lectures وشكرا لكم كلكم على الحضور والparticipation. We had a great time having you for the first day and I hope you guys will be back for our second day.